You would also think that with an organization like the National Institute of Clinical Excellence, with primary care trusts deciding treatment protocols, with physicians being employees of the hospitals, with all of this regulation and standardization and science going on, that the variation that we've been made so aware of in the United States, variation in the delivery of care, the cost of care, wouldn't be that much of an issue there. But it is. They refer to it as postal code prescribing, but they notice a lot of variation as well. Part of it has to do with the fact that just doctors have different ways of treating patients, and it's not easy to change. Part of it has to do also with socioeconomic status, and even there, with everyone covered by the same policy, what they find is that people who are in the higher socioeconomic strata consume more health care and manage to have facilities that have more in the way of equipment and supplies than other places. So the variation doesn't disappear with all of that science, despite the best efforts. If we look at their results, so how good is this healthcare system? What we see is that if we look at breast cancer, remember they start screening 10 years later than us, they stop screening at age 70, they do about 1/3 as many mammograms during the space between 50 and 60. They diagnose breast cancer less often than we do. They have a death rate from breast cancer that's a little bit higher than ours. If we look at most cancers, what we find is that the United States does better than Britain, and in fact does better than most countries in the treatment of cancer. However, if we look at cancer of the cervix, and again recall they're doing a fraction of the number of pap smears we do, we diagnose cancer of the cervix more often, the death rates are identical in the two countries. If we look at cancer of the colon, we screen with colonoscopies here most often. They've just begun screening with doing a stool blood test, and yet the incidence and death rates are about the same. Lung cancer, basically what we're looking at there is a disease that is not easily treated. And so what we're looking at is a read of the frequency of smoking, particularly in people over the age of 50. And although smoking has become significantly less common in this country, if we look at people over the age of 50, the percent of people who are smokers in this country or who are past smokers and who are over the age of 50 is higher than it is in England. If we look at younger people, if we look at the population as a whole, smoking is less common here at this time than it is in England. So about 20% of the population in the United States smokes, whereas it's closer to around 25 or 30% in England. MIs, they're doing a little bit better than we are. That may relate to obesity. Obesity is considerably more of a problem here than it is there. If we look at stroke, we're doing better than they are, and they've identified stroke care as being one of the problems in their system, and it is one of their focuses. And another way of looking at these results is this graph here. That is basically the message here is that we're doing a little bit better than they are and that most countries are in cancer. But the piece I want you to take a look at is injuries here. Automobile accidents, violent crime, suicides, things like that. If we take that off of the bar, the results are about the same in the two countries. And in fact, automobile accidents are considerably higher as a cause of death in the United States than they are in most countries in Europe. In violent crime, as you've all probably heard, is also much more common, although interestingly suicides are considerably more common in France and Germany and many of the other European countries than here. I was surprised to learn that as well. But this accident piece is worth thinking about, because if everybody got health care tomorrow, they'd still be crashing their cars, they'd still be shooting somebody at the corner store, and that piece, that bar, isn't going to go down with universal access. Everybody with a bullet in them has universal access, and that's not going to change. So where are they saving money in this system? Because they are saving a lot. They are the least expensive healthcare system in Western Europe. They are getting the job done for way less than half of what we pay. And if we look just by comparison at the cost of healthcare systems, probably the most expensive single-payer system in the world is Medicare. Right now, the United Kingdom, with 60 million people, is taking care of them for less than half of what we are spending on Medicare in this country to take care of 40 million people. They do it for £100 million a year, including the investment in private health care. And the budget for Medicare is in the vicinity of $400 million, which no matter how we correct the pounds and the dollars on that, we're spending a whole lot more. They save money there by no pharma advertising. They tried permitting it for a while, they quickly stopped it. Hospitals are put on budgets, and needless to say, they're not advertising. The GPs are paid per capita. Specialists are salaried, so the incentives for doing tests that aren't absolutely necessary are gone. And I think even more important is that the patients return to their general practitioners after they see a specialist. Remember, the hospitals call themselves acute and emergent. They don't call themselves chronic. And so if you get in to see a specialist, the specialist assesses you, he gives you a plan, he sends the plan back to your primary care doctor. He might give you one prescription, but you're getting your refills from your primary care doctor, and that's where you go back. And if you think about it, look at what you would see if you had a patient in this country, let's say she's a woman, let's say she's 40, has asthma and hypertension and diabetes. She may see her general practitioner once, she may see her gynecologist once, she may see her diabetologist twice, her cardiologist twice, and her pulmonologist twice. That's about 8 visits in a year. In England, she'd see her general practitioner twice. And that, I think, is responsible for a huge savings in their system as it goes. And their preventive medicine is much more modest. And although many of us have heard in the proposals that have come forward that preventive medicine is a cost saver, that if we just give people access and we get all that preventive medicine in there, they won't get sick, and therefore they won't cost the system money. For flu vaccines or polio vaccines or very inexpensive treatments in high-frequency infections, that makes sense. It does save money. But if we're talking about mammograms or pap smears or colonoscopies or cholesterol screens, many of the things we do, most of the things we do, 4 out of 5 of the various kinds of preventive medicine that are out there, those treatments come at a cost, not a savings. And the cost is in the vicinity of somewhere between $10,000 and $50,000 for most of those tests per year of life saved. So if we have 10 patients who gain 10 years, then that's 100 times $50,000 is what the cost to the system is. And the reason for that is that most people aren't going to get cancer. 95% of women aren't going to get cancer of the cervix even if they never have a pap smear. So we're screening 100 women to try to protect 5 of those. If we look at cancer of the colon, it's the same. 95% of the population is not going to get cancer of the colon, but we're screening 100%. And the cost for those repeated screens vastly exceed the savings on the patients who are picked up and prevented. So it may be a great investment. It's definitely worth us thinking about doing more of, but it's not going to save the system money. And this is a system where with considerably more modest screening, they have proven that they can do things for much less money. What do we make of all this? Well, the overhead issue is not going to come down for general practitioners necessarily. Accountable care organizations, which are being proposed for the state of Massachusetts, are going to impose limitations on choice. And even in England, where limitations are accepted much more readily than they are here, that is becoming less of an acceptable thing for them. The medical home, which is really the way the general practitioners there run their offices, seems to be working out well. And the general practitioners there seem, in my opinion, to be doing a very good job. They do pay for performance better. By letting the doctors look at the information first, confirm the data, put real money into the system for them, and the like, I think that they do a very good job. It's one uniform system for everyone. Preventive medicine, as I mentioned earlier, is not a cost saver, and comparative effectiveness or cost effectiveness is not immune to the political process. And if it's not immune in England, it's definitely not going to be immune here. I think it's important for us to do, but I don't think it's going to be painless. And sadly, burnout for physicians seems to be everywhere. And I don't think that changing the healthcare system is necessarily going to be a panacea for us regarding that.